to introduce Chief Kevin Hall. And so please welcome Chief Hall.
Appreciate you, I appreciate you inviting me to have a chat with you. I've been doing a lot of this since I've been here. I'm deep in my 6th month, so half a year. Yay. It's been very busy. You know, I walked into a pretty not great budget situation. But the administration, all the cabinet heads turned it around, did a really fantastic job. Actually, I was amazed what they were able to do. So a little bit about me. If you haven't heard the story, and I feel like everybody in the city has heard this story, but I was spent 32.5 years in Tucson, Arizona as a Tucson police officer. I rose through the ranks. I held every rank in that agency, from patrol officer through detective to sergeant to lieutenant, all the way up to assistant chief. Spent my last 7 years there as an assistant. I had to leave. And I felt like I still had more gas in the tank. I had more things I wanted to do. I'm a huge proponent of reform and changing police, and sometimes, and particularly in the policing sort of environment, reform is seen as a bad word. I see it more as we just want to be better, and people just want to have better police. And they deserve better policing. So a lot of that has to do with policy, it has to do with training, it has to do with mindset, it has to do with executive leaders like myself who are looking out beyond what traditional policing looks like and trying to enhance what we can do and how we can serve it. So I looked around. I was familiar with Spokane. I have relatives up here, just a little bit west of here. So I've been coming up here since I was a kid. I've known Spokane ever since I was a little kid, because we would come up here during the summer to visit my relatives. And when the opportunity came up, I took a look at it. I sort of surreptitiously came up here and visited Spokane again, and just hung out around town, downtown, met community members, talked to people, got their ideas of what they thought about the police department. And then I decided this would be a pretty good fit. So I put in for the position. And then as I went through the process, I decided more and more, this was a really good fit. I really like the administration. You know, Mayor Brown, whether you like her or not, is an excellent administrator. And she has a lot of faith in me. We got along great. I think she put together a really good leadership team. I got along great and continue to get along great with all of them. So it just felt like the best place for me. And luckily I was selected for the position, and I moved my family up here and bought a house, and here I am in Spokane.
Welcome.
Yeah, that's a little bit about me. I grew up in Southern California, however, and spent my first 18 years down there in Southern California. I went into the U.S. Air Force for 4 years. I always say that's a good way to grow up, but I didn't want to make it a career. It was good for me to grow up there, but 4 years was not my and I mostly went into the military. A, I didn't know what I wanted to do with my life, and B, I had no money whatsoever. So, what the Air Force did to me, what the military did for me, it made me want to go back to school, and they actually gave me quite a bit of money to do that after I got out. So I went back to school. I got 2 degrees, a bachelor's in sociology, a bachelor's in psychology. And then I went to Tucson to start my career there. That's my life in a nutshell. On the personal side, I have four boys, all adults now, and 3 grandsons, so it's all boys all the time. Or this is all. I've been married for 32 years, together for 36. So, yeah, and I owe everything I've done in my life, and I contribute to Dear Mrs. Hall. We can't be successful without our partners. So that's me. I think there were some questions that were thrown out when I didn't think I was going to be here. I'm supposed to go through this odd 2-week executive academy for the state so that they can bless me to say I'm a state certified officer. I was able to get out of that this time. I have to go back in May and do it. So here I am. But the questions that we talked about, one thing that's sort of been my passion project since I've got here, as much research as I did before I came here, I didn't realize the vacuum, just the dearth of services that are here for both behavioral health and substance use. And it really struck home when I got here that there wasn't a 24/7 MAT clinic, that there wasn't a 24/7 no wrong door crisis response center. And so what I learned very quickly is that officers were doing one of two things with folks who really needed behavioral health care or substance use treatment. They were either going to the emergency room or they going to jail. And that was it. That's the fork that the officers had. That's the option. They had no other option. Or they could just walk away, which officers do not like to do that. The problem with jail is there's no treatment there. They don't get treatment in jail. And the problem with the ER is they're not set up as a psychiatric ward or to deal with substance use issues. They're already understaffed and overwhelmed with medical emergencies. So they just want to get those folks out of there as quickly as possible. So I came up with this idea after talking to a whole bunch of different folks, Pioneer, Frontier, Empire Health, about this third place. We have ER, we have the jail, we need a third place. And what I'm used to from where I'm from is a 24/7 no wrong door crisis response center, where an officer could drive in, drop an individual off who's either a behavioral health crisis, needing substance use treatment, or had co-occurring disorders, and they were accepted no matter what. And then the officer was out of there. They had a 10-minute turnaround for either what we call low acuity or high acuity. So what's missing in Spokane is that place for high acuity, for folks who are involved, who will be involuntarily held for an assessment period. Right now, we have a great crisis stabilization center right down there by the public safety building. But that's strictly for voluntary folks who say, yes, I want help, please take me to that center. They will not take involuntary holds. That's our biggest issue. And I would submit when you, as you drive around and you see folks out there, my officers are engaging with them daily, and they will touch it and say, and I've seen it and I've been out with them, and this person cannot make an informed decision about their own care, and yet we don't have the tools to take them involuntarily to get a clinical assessment and get the help. So that's what started this whole process of trying to figure out how do we build a system where we can make sure that these folks get the care that they need. They can go in for 24 hours and get stabilized. If they need antipsychotics, they can get antipsychotics. They can start working with street medicine with Chaz. Chaz has a great clinic down there, and we can hook them up with Chaz. Those kind of resources are plentiful. It's that initial intake where we're struggling. And if people say, no, I don't want any help, but they obviously need help and need help bad, then we're forced to walk away. And that's a shame. And the community deserves better than that. Both the very vulnerable population, as well as the rest of the community. These are public spaces that we all should enjoy for free. But this is what compassionate policing is. I also talk a lot about compassionate policing. People say, well, that's not what police are supposed to be doing. And I would submit it's exactly what police should be doing, solving community problems. I call my cops community problem solvers. Whether they like that or not, I haven't quite figured out, but that's what they do 90% of the time. They're just solving community problems. Very little amount of their time is actually enforcing the law. So I've been working on this, and there's a lot of barriers. There's state law that really causes some challenges for what I'm looking for. The ITA laws are really restrictive. We have this process, and I'm sure there are people in here who know more about this process than I do, with the DCRs or designated crisis responders. They're the only ones who could do a clinical assessment and actually hold somebody for a period of 24 to 72 hours. Gotcha. So I'm trying to figure out how we can work with the legislator to ease up the restrictions surrounding these designated crisis responders. So maybe they can be at an ER while we're building this third place, and then eventually they'll be at the third place. They can do the clinical assessment right now. What's happening is my officers are taking these folks to the ER. The officers are leaving. The ER docs are saying, I don't want you here. You're out, discharged. And when the DCR gets there 90 minutes later, the person's already gone. They can't do a clinical assessment. It happens over and over and over. We also talked about putting a DCR in the jail so that these folks can get clinically assessed in jail. I'm not a big fan of that because that will then create more jail runs and more people getting injected in the criminal justice system that probably don't need to be. And there's also conversations with the county, and believe it or not, we are collaborating with the county on trying to figure out this problem. If they can build a new facility for the jail, and I'm not here to advocate one way or another, but I know the jail is falling apart. You know, maybe they would have a treatment center there. I would say that's not a great idea either. Treatment center needs to be separate from the jail. I would submit the most successful models out there, the treatment center is connected to a hospital. Right next to an ER, a lot of these folks need medical care before they can be clinically assessed. So that's what I'm working for. When you hear, whether you hear it or not, I do talk about the third place a lot. People are probably sick of it, but that's what I'm talking about, is that model where we're not taking them to the ER and we're not taking them to jail, we're taking them to where they can get the treatment they need. And if it's an involuntary hold, so be it. It's a 24-hour involuntary hold, so they can be stabilized, so they can get the medications they need, so that they can get connected to the services they need. Housing, behavioral health, or substances. So I know I'm running out of time. That's the third place. There were a lot of questions about that. Other things people have asked me about that are really prominent here in Spokane, and that's fentanyl. I would submit, having been doing this for over 33 years now, fentanyl changed the landscape of almost everything we do in substance use, behavioral health, and homeless outreach. Everything was working up until about 5 years ago, and fentanyl changed everything. It is such an addictive drug, and it just it's devastating. And it is so hard to get people to engage in services when they're using fentanyl. And almost all of our folks, once again, some of you probably know this, are polydrug users. They use both methamphetamines and fentanyl. They calibrate with each drug. One's a stimulant, one's a depressant, and then that's how they function, by calibrating with these drugs. And like I said, a lot of them have co-occurring disorders, so they're self-medicating to address their behavioral health issues that they have. All of this, well, I would say all of it, a lot of this is treatable if we can just get them into treatment. And not inpatient treatment. Once they're stabilized, outpatient treatment is really successful. And you're probably wondering, why is the chief of police talking about this? Because this is a huge problem in our society. And my cops see it day in, day out, day in, and there is no solution right now. That's why we're addressing it this way. But even the homeless outreach providers are saying fentanyl changed the game. We cannot get people into housing whatsoever. Behavioral health said changed the game. So that's why we're really struggling to figure out a better way to be more adaptive and flexible to get the folks that we see who need the help to get the help, to be stabilized, and then to move on to have a healthy, productive life. I got 1 minute.
Do we Q&A now or
After the 1 minute,
Okay.
we can start now?
whenever you want.
This is a good set. Q&A. Yes, ma'am.
What can we actually help with?
You know, I was thinking about that. I was driving over. I'm sort of crafting. It started out to do a one-pager on that 17. And a part of this is policy work. Because I started, as I just said, I started thinking about, well, what do I have to change legislatively to make some of this happen, and that's policy work, and so I gotta start working at the state level, the legislators. And I've already talked to folks in Seattle, my peers over there, and they're on board. They said, yep, this is what we've been looking for. People down in the Tri-Cities said, yep, this is what we've been looking for. Everybody knows this is what we need. We just need to start influencing our policymakers so that we can start doing this in an effective, safe, and compassionate manner. So as we move forward with this and we start, and I get a little bit more down on paper, I think when I write, that's why I write a lot, is then we start laying out what those changes are, what those policy changes are. And that's when I'm going to reach out to groups like this and say, this is what we're looking at, and tell me what we're missing. Or does this resonate with you or not? To try and get, I learned a long time ago, to be successful, I'm not doing this alone. It has to be with the community. It has to be with groups that are interested and invested. So I need that. And that's what I would do, is push this out. I've spoken to tons and tons of groups. And believe me, I kept all the contact information for justice reasons. Push this stuff out.
We have a question on the audience, on
Okay.
the screen. Yeah. Go ahead, Rowena. Go ahead.
Thank you. Thank you for your service and all your effort. My question is, when it was hard to hear, but 24-hour stabilization or voluntary stabilization? I think most likely. Can you hear me okay?
If you could clarify a little bit.
Yeah, so
The difference.
So a 24/7, no wrong door facility is for high acuity patients, meaning they could be both voluntary or involuntary. Right now, there is no involuntary 24/7, no wrong door facility in Spokane or in Eastern Washington, quite frankly. So that's the difference. The stabilization center, which is a wonderful center, is all voluntary. People have to say, I want to go there. We can't take people there who don't want to go there.
Okay, does that answer, Aruna?
Yeah, and the other question, so it's for high acuity people who are not accepting that they need help. So we need for, and so the policy changes is, what direction, which legislators are you targeting? You know, we can, like Senator Dhingra, you know, leading, you know, the healthcare committee, not healthcare, but the behavioral health committee. Because we will have to educate the legislatures too about the issue, you know, after the session, so that before the next session we can get drop the bills that would work with our population and our needs.
Did you catch that?
Yes,
Okay.
That's an excellent point. I'm not ready right now. We are just beginning this. Like I said, I've been here 6 months. So I think it's going to be next session where we build out enough policy modifications and things that we want to do. We can reach out to our own lobbyists. The city and the county both have lobbyists. And then we reach out and start finding sponsors at the state level who are willing to carry this forward. And that's when I will reach out to you folks and say, here's what we need from you.
Oh, Lunel had her
Yeah.
hand up first.
Question, this is rumor control or fact checking. It's my understanding that I think associated with the University of Washington, there was a behavioral health center built but not utilized. Do you know anything about that?
I don't, unless you're talking about the youth wing, psychiatric wing at Deaconess, which
Not-
is shut down.
No, but just sure.
Yeah, just the shit.
Sacred Heart too. right?
It was at Sacred Heart.
Oh, sorry, Sacred Heart. Yeah,
There was
that's
one here.
that's
too.
the only one I'm aware of, but once again, I'm new. I'm the new guy here. Yes,
What does no wrong door mean?
no wrong door means that when a first responder shows up with an individual, a crisis of behavioral health issue, substance use issue, no matter what the issue is, they take them. They don't say, no, that's for somebody else, or they need to go to the hospital first. Why it needs to be close to or connected to a hospital. They take them no matter what. No wrongdoer.
So they're the triage assessment.
They are the triage and they're also the clinical setting. Yes, ma'am.
How many people that are street homeless would you say don't have a mental health challenge or a drug addiction?
Oh, I would just be guessing. I'm trying to remember the last article I read, the academic article. Something like 40%, only 40% of unsheltered or homeless folks are actually chronic drug users. I think that was an East Coast city where they did that study. So like I would be guessing. I know that the chronic folks who have been homeless for 10 years or more, there's almost always going to be some sort of behavioral health connection there.
Because I think the law, they changed the law last year so that if they're actually using drugs in public, then you have the authority to arrest them, right?
Yes, we can arrest them. It's a misdemeanor arrest. The jail. Here's another sort of rumor that's going out there is that there's no beds at the jail. There are beds at the jail. The jail is a staffing issue. They don't have enough staff to bring in any more inmates. And if you haven't taken a tour of the jail, they do tours. I would go because that place is awful. It is medieval. We do need a new jail. I just don't know if we need a giant jail. It's just a horrible place.
Go ahead and take someone else.
Yes, ma'am.
We have a criminal justice reform committee, and there are lots of questions. One of the things I've been trying to get a handle on is who does the framework for the next ballot measure on the jail? Because I've been thinking that there are all these kinds of things in our community, like you're saying, and outside of the jail, this kind of cult. And so who's in charge of that? Do you know?
I do. And that, I would say, is not my story to tell.
Yeah.
There are a host of elected officials involved in this collaborative effort, which is one of the reasons I started doing this, is because they weren't really talking about this, and I need them to start talking about this. So yeah, that's all I'll say. I think something publicly will be put out within the next 2 weeks from that group, of which I'm a part of, but that's for the elected.
To find out the main body. Is there a main body or is it all over the place?
It is elected officials from both the county and the city.
Is there anyone in charge?
Yes. Once again, I'm not feel that is gonna be revealed publicly by them. This is their story to tell. And it will be told here very quickly.
I wanted to ask one more question. Like you're talking, there's no room in the jail. Now, years ago, I heard that we were giving space in our jail from other counties and cities in the Northwest. And even the federal government, when we had out there at Airway Heights, they were using us. So I want to know how many beds we have and why we don't have room in there. Is it because of the people that were housing from other places?
No, they actually have pulled back on all of that. And they've also pulled back on most of the misdemeanors. I think it's only about 5% of the inmates now are misdemeanors. It's all felonies now, on almost all in-county felonies. It is an issue of staffing. There is a dashboard, I think it's internal, and I don't think it's a public facing dashboard, but I can go on and look, and I haven't looked. There's almost always anywhere from 90 to 110 empty beds. They don't have the staff to safely bring in that amount of people. They are but they do what's called red light status, which drives my officers crazy, which means they shut down. And if my officers are in queue waiting to bring somebody in, then they just sit there and wait until they open back up to allow more folks in. And that's because of their staffing issues.
Right now, vacancy.
Right. And then, I mean, it starts worrying if my officers have somebody in the back of their car for 3 or 4 hours, we're starting to look at constitutional violations, and we're really worried about that.
Yeah. Thank you so very much.
Okay, next up, we have Dr. Bob Lutz. He has worked at local and state level public health, and we're really delighted to have Dr. Lutz with us.
Thank you. So I was really encouraged by what Chief Hall said. It's a pleasure to hear that kind of approach. Background, public health, I've been doing medicine for the last almost 3 years. So the population that Chief Hall is talking about, the population I serve. And I will provide some data for you, percentage of individuals nationally. Difficult to capture that locally. I'm going to provide a whole lot of data, and I apologize, it's kind of black and white. And I would also say it's kind of dark, because the data are not very positive. And so I've been called Bummer Bob. Oftentimes the data I present are very depressing. You'll hear nationally that yes, we're seeing a decrease in overdose deaths. We're not seeing that in the Northwest. Certainly not seeing that in Washington State. Maybe a little bit of it suggestive on the west side, but certainly not in Spokane, and I'll show you those data. This is a portable toilet that was at track last year. We pulled somebody who overdosed out of that facility. He had been dead for about 6 hours.
Wow.
Unconscionable in my opinion. Next slide. Next slide.
It's delayed, I
I'm
guess.
sorry, yeah. So just the map, you can see dark is not good. Those are counties across the state. Again, 2023 data, which are finalized, 2024 data preliminary, but you can see the darker the county, the worse the rate of overdoses. All substances. Next slide. Also, I should tell you my 2 data sources are DOH, and then there has been a new data source that I got turned on to. It's a coroner and medical examiner from across the state. And so these data are heat maps. This is from 2022. So not surprisingly, metropolitan areas are where you're seeing the highest rates, and a little bit going on down in central Washington, Yakima. Next slide. Notice the movement. You'll see going up that central Washington corridor, and then again going east and west. And then from 2024 data, next slide. So again, concentrated primarily, is this the 2020?
Yeah.
Okay, yeah. So again, you just sort of
Can't
see
tell,
how
but
it, yeah, again, it's much, I mean, interestingly enough, it's much in the rural counties. They've not been spared, but also the major metropolitan areas, as I said, as it's spread up the central Washington corridor and then east and west. Next slide, please. So overdose deaths, all drugs, and you can certainly see any drug is just what it says. I will talk about some specifics, but do note heroin from 329 in 2018 down to 29. Heroin you can't find anymore. People are looking for it, but people, as Chief Hall have said, they've made the switch. When I was a health officer, the first, and I'll talk about this, the first overdoses that I saw of fentanyl were in 2019. Okay. Back then, we were trying to discourage people from using fentanyl test strips. Now everybody's using fentanyl because, as Chief Hall said, it's an incredibly addictive drug. Not only does it give you that euphoria, but also there's animal models that show that it also, unfortunately, causes you to have that negative effect, i.e. withdrawal symptoms. And if anybody's heard about being dope sick or in withdrawal, imagine the worst possible flu plus the norovirus. Okay, so you feel like the worst. That's what fentanyl has done. So you get the euphoria, the high, and you get the low, and you, again, do not want to feel that badly. So you're going to use, and you're going to use, and you're going to use. Next slide. So these are, again, data, and again, you can sort of see, looking at right now from this new data source that I have, again, medical examiners and coroners' offices, we're looking at about 2,800. Now it's not quite 100%. We're at about 70% of ME and coroner reports across the state. But I think it's pretty good. And it's obviously more current than what I'll provide to you from DOH data, but irrespective, you can sort of see from a race ethnicity, our Black and brown populations have been disproportionately impacted by substance usage.
no different than what we've seen over the decades. I will tell you that people use substances because they do not like the way they feel. They want to feel differently. And when you have marginalized populations that want to feel differently, substances are readily available to them. The drugs people have made them available, and it gets them hooked. So by gender, it's primarily male. You can certainly see by age, again, two big peaks, 30 to 39 and 50 to 59. Next slide.
Patience. There you go.
So again, just by year, again, it's contributing substances. Bottom line is it's fentanyl. It's fentanyl. As Chief Hall said, it's polysubstance. People titrate. Also, they'll find out what's available. Okay, what's readily available, what's cheapest. People will certainly find their drug of choice, but we also know that their drug of choice may not be available, and then I will use what I have available to me because you know what? I want to feel differently. Next slide. Fentanyl, again, dark, speaks for itself. Polysubstance, again, primarily polysubstance now, no longer just one drug, it's mixed. But again, because of the way fentanyl works, because of its respiratory depression, people are dying from primarily fentanyl, but they have polysubstance usage. Next slide. This is an important slide, I think, that I really want to emphasize. I'm going to move in front of it, I apologize. 55%, more than half of the percentage of this population were not homeless. They died in their homes, folks.
Yeah.
So please accept the fact that the narrative is wrong. Pure and simple. It has changed. 55% of the people who die of overdoses are housed. Not what you're going to hear, but that's what the data says. That's the reality of it. Okay. And when we also talk about mental health, now there is serious mental health. You're people with schizophrenia, schizoaffective disorder. About 20 to 30% of individuals living homeless have serious mental health issues. But I emphasize this: anxiety and depression. That constitutes almost 45% of the mental health issues that people are dealing with who have substance usage. I can tell you that I certainly deal with people who have schizophrenia and are homeless. But the number of people who are living homeless who have anxiety and depression, exponentially greater. Put yourself in their place. Okay, you've lost everything. You have something taken from you. I have medications that all of a sudden I've lost because they've been stolen from me. Okay, we have sweeps, unfortunately, that take people's stuff. And then do they get them back? Rhetorically, I ask. So again, I think that there are reasons why people use drugs, and we can't just say it's because they have mental health issues or that it's serious mental health issues. It's depression, anxiety. Yes, we also see serious mental health issues, but please do not think that because people use drugs by default, they have a serious mental health issue. With respect to co-occurring disorders, we're talking about 20 to 40%. Nationwide, co-occurring disorders, substance usage, and a mental health diagnosis, anxiety, depression, serious mental health issues. But the narrative that's out there, I would argue, is not an adequate or correct narrative. Next slide. So in Eastern Washington, primarily Spokane, heroin way down, synthetic opioids way up, fentanyl methamphetamine never went away. Next slide. So if I touch the slide,
No, it's getting quicker.
oh, no, I'm saying if I just touch that.
No, I guess not.
No, I leave a little mark on it.
Oh, you do?
Yeah,
Oh.
so our rates, you'll notice the highest rate is in Yakima, but all the rates over here, okay, rates per 100,000, so 44 for 100,000, the rate in Spokane. Every other county is west of the Cascades, with the exception of Yakima, which is an epicenter of substance usage and drugs coming up, and then Spokane. Next slide. This is what people are, again, any opioids, synthetic opioids plus prescription, way down. But again, you consider any opioid is synthetic plus prescription, DOH data. Next slide. Again, males versus females, Eastern Washington versus Washington State as a whole, not dissimilar. Next slide. Age groups a little bit different in the Eastern Washington versus Washington State, but irrespective about the same. How am I doing this time? 5 minutes, thank you. I'm going. I can talk really, really fast. Okay, and then again, the disproportionality between race and ethnicity that we've seen in Eastern Washington, but also, again, across the state. Next slide. Bottom line is that Eastern Washington is the solid line projected. Okay, so we're seeing, again, across Washington State, we're seeing projected decreased rates of overall OD death, not necessarily for Eastern Washington yet. Okay, next slide. And if I look at counts, all drug and opioid overdoses, this is again preliminary data from 2024, but you can certainly see the trend up. And I'm going to give you some rates in a minute, but again, just appreciate that. Next slide. Rate going up, again, exponentially increased since 2019. Next slide.
Oh. Something happened for sure.
So while we're looking
Yeah,
at that,
pardon me.
let me just give you some rates, which for me are just phenomenal. Okay, as I mentioned, when I was a health officer in Spokane County, the first fentanyl deaths I saw in 2019, we had 6. We had 6. In 2024, projected so far, we've had 230. So if I look at a rate, 23 full confirmed data from DOH, 2,800% increase since 2019. If I look, overdose deaths due to fentanyl was pathetic. If I look at projected preliminary data for 2024, a 3,700% increase, 3,733% increase since 2019, when I had 6 individuals. If I look at polysubstance, 175 with preliminary data, I should say for confirmed data for 23, and for 2024 preliminary data, 630% increase. And for psychostimulants, i.e. methamphetamine, 710% increase. Preliminary data for 2024. Drug overdose deaths have not gone away. They're not going to go away. We need to do something collectively. I am incredibly encouraged by what I'm hearing from Chief Hall, because it takes a community, a collective effort to find solutions. To date, we've not really had those solutions. We do not have enough MAT providers. We do not have enough resources for people with mental health issues. And we really need to decrease the drug usage drugs coming into this area. We're back. Okay. Sort of. Next slide then. And I've got 2 minutes. So synthetic opioids, again, that's fentanyl essentially. And I make the difference, illicitly manufactured fentanyl. Fentanyl is a prescription medication. If any of you have had a procedure, be it a dental procedure, a colonoscopy, you have had fentanyl. And you know what? You don't remember a whole lot, and you went up really quickly. Illicit manufactured fentanyl are very different. It works the same, but I call it the chocolate chip cookie effect. If you get a drug, illicitly manufactured fentanyl, a pill or powder, you know, in chocolate chip cookies, you find, hey, there's one part of the cookie that has a whole lot of chips, another part has nothing. The same thing with powder, the same thing with drugs, with tablets. A little bit has some, the other part has nothing, or it has a lot. So people have no idea what they're getting, and they overdose. Next slide. So again, I gave you these numbers. You can just sort of see they speak for themselves, but the trends are up. The blue is preliminary counts. Next slide. Rates for 100,000. Again, synthetic opioids, so fentanyl. Next slide. Stimulant drugs, i.e. methamphetamine. Sort of a plateauing for us in Eastern Washington, but certainly going up. And then, as I said, also, and then you can see that. Next slide. Psychostimulant rates. Next slide. Polysubstance, what Chief Paul talked about. 1 minute, okay. 2 slides. Next. I don't have to say anything. I just let the slides, remember, speak for themselves.
You can say something because the people,
Okay, I'll say something, but I really don't need to say anything. Look at the slides. Next
they
slide.
can't.
Oh, they can't see them?
No, the
Oh.
Zoomers, these people, they
Oh,
can't.
bummer. But Zoomers can't see them. Okay, bummer.
It is what it is.
Yeah, okay, next slide, please. The rates are going up. This is EMS, this is EMS, emergency medical services. What happened in September? We had an incredible spike in September. Over 200 people overdosed in the month of September. Wow, okay. Bad batch of fentanyl, hot, yeah. So next slide. Again, by age, you can certainly see the, you know, the 2 peaks, 35 to 64, and then 18 to 34. Next slide. This is where you can find overdose data from DOH. I'll make these slides available so you can have access to them. And next slide, that's it. Yes, ma'am.
Fentanyl's coming from somebody in the region that's making it, or is it coming from other parts of the world, like, like people that are overdosing, what is their source? Do you have any idea?
I don't, but what I will tell you is that it's incredibly easy to make. But why make it when you can buy it cheap coming up from the south? So again, I think Chief Hall could speak to that much better than I, but in contrast to what we've seen historically around drugs like methamphetamine, where you had CDLs, clandestine drug labs, and CDLs, clandestine drug labs for fentanyl. Now that this is coming fresh, it's already made, it's easy to make. Chemicals are coming from overseas, from China, being manufactured in Mexico, elsewhere, coming up. So I don't think, and I would turn to you, sir, I don't know if we have CDLs, clandestine drug labs in the area. Certainly meth was huge, but why cook something when you can buy it for cheap?
I used to work at Deaconess in the chemical dependency unit there, and we always used to say that we really needed just the detox unit because a lot of these people came in and they ended up in our intensive care units. And so there really wasn't really good drug care. And until they got over detox, they really couldn't even go into anything. And I just wondered, do you know anything how it feels now in Spokane for a drug rehab? Like, can you go in, like, do you see fentanyl people come in and say, I need to get off this? Or are they just overdosing because you say like, it's just.
It's not black or white. There's no like, here's the answer. I think Hallie will speak to this a little bit. I think that as Chief Hall said, and as I will also say, and anybody who's in this domain will tell you, fentanyl has changed the dynamics significantly. No doubt, no doubt. In my street medicine capacity, I will see people regularly say, you know what, I'm tired of this. I can't do this anymore. This is just killing me. It's killing my family. I mean, I also do some consulting work for what's called the Office of Public Defenders that are trying to keep families together. And for me, it's very concerning when I have somebody who is working for a state agency saying a parent who uses fentanyl cannot parent. For me, that's a little problematic, but that said, it's difficult to get off of fentanyl because it's such an incredibly addictive substance. And so I think that, to your point, and I think Hallie can speak to this, we do not have enough resources in Spokane. You know, nationally, we're talking about maybe 1 out of every 5 people who want treatment, who need treatment, have access to treatment. I would say our numbers in Spokane are not much better, if not worse. You need to look at it.
No, we have a question from
Yeah.
someone on Zoom.
Aruna.
Bruna.
Aruna.
Thank you very much, Dr. Lutz, for the informative presentation. My question is, why is the projected death rates expected trend upward in Eastern Washington, Spokane versus whole Washington or Western Washington? Thank you.
If I understand, why are the rates higher in Eastern Washington as compared to Western Washington? Are you familiar with what we call the social determinants of health? So these are, again, the conditions in which people live, work, and play, and have grown up. And certainly our rates of poverty our rate of ACEs, adverse childhood experiences, these are all much greater in Eastern Washington. So you've heard years ago, there was a researcher, Angus Eaton, who talked about the diseases of despair. I would argue at some level that substance usage is a disease of despair. Life is tough. And when you don't have a way out, this provides you a way out. The demographics in Eastern Washington are different than Western Washington. Our social determinants of health factors, if you will, our indices are higher. And again, when you've got no way forward, you will find a way to get you through the day. And drug usage, unfortunately, gives for some people that way forward. Yes, ma'am.
What do you think the mix is of people who become addicted, who became addicted through, you know, medications that they were actually given, and those who, you know, started using it recreationally or just because, you know, they're feeling miserable?
Sure. So let me, if I may, and words matter to me. And so I do not use the term addicted, but rather someone who has substance use disorder. Okay, because we know that this is a neurophysiological changes that occur irrespective of your use disorder. We know that the same neurochemistry applies. So to your point, I think that unfortunately you've heard about how much of what we're seeing right now, what's called the third wave of the opioid epidemic, that was initiated because of the pharmaceutical industry. No question. No question that was a contributing factor. I would also rhetorically ask you, though, why, if I look at globally, it used to be again that 80% of opioids that were manufactured worldwide were used in the United States. So again, I come back to the fact that we're a society in pain.
Yeah.
We're a society in pain. You know, as a public health practitioner, this is the world I lived in. You know, and it's easy to speak disparagingly of those people, but the reality is that you gotta find a way forward. And for some people, the only coping mechanism they have, because they've got no other resources available to them, there's no social safety net. You know, it's been thrown asunder, it's been torn asunder. And so my way forward to get through the day is to use something that makes me feel like I can get through the day. So, but don't get me wrong, certainly a percentage of people. I am still the health officer in Spokane County, and I have an older population down there with a lot of chronic medical conditions, arthritis and things of that sort, who got put on opioids. I saw a woman, and I'll stop calling you.
No, you're fine. There's
Oh,
just one
okay.
more.
I
One more
saw,
on the line.
I saw a woman a couple of weeks ago doing my street medicine work, really sweet woman, in her 60s, chronic medical conditions, including a lot of orthopedic issues, and had been in a chronic pain clinic for years. And then, for reasons unclear, I didn't have the whole story, but for some reason, the provider decided that it was important that she be weaned off of her opioids in the span of 3 weeks. So that doesn't happen. It doesn't happen. And so what happened? She turned to fentanyl.
Yeah.
Because it was cheap. And I can get my pain management off the street. Luckily, she hadn't overdosed yet. I always give out naloxone for obvious reasons. If you're giving an opioid prescription, make sure you give out naloxone as a provider. But that's unconscionable from a provider standpoint, that I'm going to make somebody go cold turkey. You don't do that. So I think, again, long answer, short question, that's what you get when you ask me a question. I apologize. I think that there are numbers out there. I don't know the numbers, but definitely there's a percentage of the population. Also with orthopedic injuries, a lot of people that I talk with, kids, athletes, they were given some hydrocodone, some Lortab because they had a knee injury, they hurt their back, what have you, and oh. I had somebody tell me, you know, we are all just one substance away from substance use disorder. It's a matter of finding the right substance. That little key in the lock. Wow, I feel really good. I never felt like this before. I'm going to chase that dragon. I'm going to keep on using this substance because I feel really good. We're just one substance away from substance use disorder. So,
Aruna?
We're gonna wait on,
Oh, we're gonna wait on.
we're gonna try and see if we can wait until Adam.
Oh, okay,
Get Hallie done,
okay.
and then we'll come back.
Yes, Mike.
So, you've talked about a lot of things, deaths, the population and things like that. Could you briefly talk about the rehab programs? Are they successful? Are they affordable to the people that need them?
Yeah, so the question is about rehabilitation programs and are they successful? It depends. Okay, acknowledge that oftentimes one time for rehab is not going to be sufficient. And so this is understand that substance use disorder is a chronic disease. And so depending upon how long you've had that chronic disease, you may find yourself going back to rehab, a step forward, a half a step back, 2 steps forward, a half a step back. And you know what? It's not done in isolation. It takes a lot of compassion. It takes a lot of caring. It takes resources. It takes a community. I need to know that if I'm in recovery and my recovery started here, my recovery may go forward, it may go back, but you know what? There are people there to help me along because life's tough and triggers. All I need to do is have one trigger. I have a bad day. Okay. I can't pay this bill. Something happened to me. Oh, you know what makes me feel really good? I'm going to turn back to this. So does rehab work? Yes, but it's not, again, black and white, and it's not by any means linear. And do we have enough? No, not even close. I mean, trust you me, and Hallie will speak to this. We have such a dearth of MAT, medication assisted treatment providers in our community. For me, it's unreasonable and or unrealistic that anybody who's caring for a patient, irrespective of their MD, DO, I'm a family medicine doctor, I'm a surgeon. Learn how to prescribe medications for all the issues that are befalling the patients, i.e. I've got opioid use disorder, here's some Suboxone. And you know what? I've got lots of medications that I can get you turned on to, I can introduce you to, that can take care of your substance use. Methadone, we've got now long-acting injectables. So imagine if I get you on medication, but you know what? I don't feel like I can take a pill every day. Well, you know what? I can give you an injection. It's going to last you for 3 weeks, a month. Wow. And I don't get dope sick and I don't have cravings. That's brilliant. We do that with antipsychotics. We do that now with opioid use disorder. So,
Super.
Thank you. Back.
So Dr. Lutz shared a lot of data and very important numbers that are relevant to us. Hallie Burchinal is the executive director with CAT, Compassionate Addiction Treatment Services, and she's going to put the human faces and stories to this. Thank you.
I'm a stories person and I have to watch myself on time, so I'm gonna try to first tackle the actual topic, which is what we have available within our community and where those gaps in care might be. And both Chief Hall and Dr. Lutz touched on those as well. Something I want to share, I did a little bit of research before coming because I'm not a research, I'm not very much a humanized social services type person. But I wanted to do a little bit of research to prepare to talk with you all. And something that I came across, I went on the Johns Hopkins website. And a couple things jumped out at me that we experience daily, but was summarized really well in some research papers. I'm going to do a couple quick quotes. One is on new research sheds light on treatment and harm reduction gaps among drug users. And they say the findings suggest that targeted public health campaigns and outreach programs are essential to increase awareness and utilization of treatment and harm reduction services. The research underscores the urgent need for improved access to and utilization of harm reduction and treatment services to save lives, addressing gaps in harm reduction practices through targeted interventions and increased awareness to significantly mitigate the overdose crises, particularly in marginalized communities. I think it's important to touch on that because the words harm reduction, please. The words harm reduction have been a really stigmatized words to use within our community, but when we're talking about substance use disorder and we're talking about people dying daily, we have to look at how do we keep people alive, and it's not enabling. That is keeping people alive is not the equivalent of enabling. It's literally keeping people alive. It's what surgeons do in hospitals. It's what we do in every other area of our culture and society. And it's what everybody struggling to stay alive deserves, is to have people try and help them stay alive. So I really want to encourage everybody to think about harm reduction and maybe how you can communicate within your community and decrease that stigma so that we can engage in those really big conversations. So I wanted to touch on that. In thinking about what Spokane has, both the chief and Bob touched on the lack of services that are available within our city. And I had the good fortune to meet with you, Chief Hall, and you brought up then the lack of a 24/7 mat availability and the need for a third door or a third option. And those are, from my experience, absolutely true. When a person is ready, they are ready. And that moment can be a blip on the radar. And if we don't have what they need to move forward in that moment, they may miss that opportunity. And then the hard reality of fentanyl is they may die before the next opportunity happens. And so having these resources, these instant available resources, is mandatory and absolutely lacking within our city. We do have a shortage of MAP providers. We've got a wide array of MAP providers, but they all are booked. This is a huge epidemic and the services are stretched thin. But some things that really jump out at me when I think about the work that we do and the ways that the barriers that we run into on a daily basis, we have folks walk in a state of determination. They walk in the door and they say, I'm here for help. I want help. And they mean right now. And we'll do a substance use disorder assessment. We'll identify their level of care, which is based on medical necessity, which that in itself can be a barrier. If you've got someone saying, I want to go to inpatient treatment, but then the counselor that assesses them says, but you don't meet criteria for inpatient treatment. You only meet criteria for outpatient treatment. That happens a lot. And people die from that. They literally die. They're denied what they need and the level of care. They knew what they needed and nobody listened. But if they come in, we assess them, they meet criteria to go to inpatient treatment. Now we need to find them a bed. So we call all the treatment facilities. We identify who has a bed. We find that bed if we're lucky. Some days it just feels like the magic 8-ball happened. Like it just, boom, there it is. And it's exactly what's needed. But now we're working specifically with people experiencing homelessness. That's what I'm most familiar with. And there's often a lot of underlying health issues that go along with that due to the impact of living unsheltered. Now the treatment facility wants medical clearance and they want the person to go through detox before entering the facility. So now we're calling withdrawal management facilities and asking if they have a bed. 9 times out of 10, they do not. And so we're sitting there with a person who's ready, who has a life-threatening situation in their lives. And we have nowhere to go with them because you're lucky to find a bed for inpatient treatment. 2, you're lucky to find a withdrawal management bed that lines up with the entry into that. And if you can't find those 2 things, you're standing there with a person who feels as though they have no option. They're going through withdrawals. They can't get the support that they need. And now they physically feel so unwell that they're exiting your building to go use and feel better. So it's really, it's hard for folks that haven't experienced substance use disorder to understand. But there really is just a window of opportunity. And if we don't have enough resources, we can't meet that need in that moment. And that life is back out there at risk. And that's really whether they're housed or unhoused. As Bob spoke to, there are a number of overdose deaths. The number of overdose deaths are higher with housed folks. We just don't hear about that as much because maybe it's not the political pounding stone, right? So it doesn't support the narrative. And I've learned, when I entered this work, I had no idea I was entering political work. I had no clue. And now I'm more versed in politics than I ever wanted to be. And I'd really like people to quit teaching me. I'd like to quit needing to know because I'm about recovery. But so those are 2 really significant issues. If we had that no wrong door option, that could immediately alleviate that situation, because we've got a person ready, we found a bed, and there's a door. Now that door, depending on the amount of beds, could end up becoming a closed door again, just to being overly full, because this is an epidemic of huge proportions. But it would increase, and it would alleviate the need to match someone to the perfect thing. There would be a thing that matched. Another thing that hasn't been talked about that I think is incredibly important to talk about regarding availability of services so that people are successful in recovery. So we're looking at overdoses, now we're looking at recovery. People, when they do make it into inpatient treatment, they do the work, and they're learning new coping skills, because that's really what treatment is about, is addressing mental health, learning new coping skills, because drugs are oftentimes just a survival method to get through hard feelings, hard times. So you got to learn what to do in place of that, and that's what treatment's really about. So they're in there doing the work, they're learning new coping skills, they're addressing their underlying mental health if that is part of it, and they successfully complete treatment, or don't. Maybe they feel they successfully completed treatment and they're ready to leave. Either way, when a person's ready to leave treatment, what are they leaving it back to? Typically the very same circumstances that they were in prior to treatment, which could be experiencing homelessness again, or back to a very toxic environment where maybe their next door neighbors were the person they used with or bought their drugs from, or who knows. And there's so many options of what that could look like. I think it's really important to acknowledge that this isn't just a crisis of homelessness. I know they would be comfortable with me sharing about this because they share so openly and publicly. But Kevin Rudine, one of the founders of the Race Rudine Foundation, Kevin is a land developer. He's incredibly wealthy. He's in the Spokane Valley. I've been fortunate to be in conversations with him, and we've also received support from their foundation. But their foundation was born from the death of his son, Race. And Race died because he completed a very expensive inpatient treatment option and left without anybody helping change the environment he was exiting back into, and he returned to the same apartment he lived in before, the same circumstances he'd been in before, and within a week of completing treatment, Race Rudine died. And so I think it's really important to acknowledge Race's story, because it elevates this beyond just the problem of homelessness. We have to look broadly at what life looks like after treatment. What do we provide people when they do all that work and exit treatment? And then when we talk specifically about people experiencing homelessness that may not have the ability to work with the team and identify, a new place to move to, they have nowhere to move to. Within Spokane, we have an incredible shortage of recovery housing options. We have some beautiful options out there, but we don't have enough. And so typically people are exiting into the very same situation. If I'm in recovery myself, and I'm fortunate that when I went into crisis, my mom, who's here with me today, I reached the state where I was going to take my own life, and she kindly drove me from Colville to the State Departmental Hospital. I'm going to thank her for that. When you return back to it, nothing's changed. And so all that time in treatment, all those resources spent, and the person's back kind of at ground zero again. I wanted, since I'm almost out of time, I want to touch on a couple other things. Actually, I want to touch more deeply on that one. I went to Johns Hopkins again, and because I think this is such a significant piece of the puzzle and doesn't get as much attention, the housing component, I want to read what they wrote from their research. Due to many factors associated with substance use disorder, there's a high correlation between housing security or the state of not having stable or adequate living arrangements and substance use disorders. The U.S. Department of Housing and Urban Development 2023 Continuum of Care Homeless Assistance Program, homeless populations and subpopulations found that roughly 108,035 persons experiencing homelessness in 2023 were also experiencing chronic substance misuse. This makes up approximately 16.5% of the total homeless population in 2023. I want to make sure you heard that, 16.5% of the total homeless population. So drugs are not the core issue, it's the most visible issue. Housing insecurity also contributes to opioid-related outcomes. Opioid overdose is more common in individuals experiencing housing insecurity than in individuals who use drugs but are not homeless. And this is where Bob showed some new data that disputes this actually. As drug overdose rates and rates of homelessness continue to increase, jurisdictions may consider using opioid settlement funds on interventions that address both substance use disorder and homelessness. A complex relationship exists between substance use disorder and homelessness. Substance use disorders can be both the cause and the result of homelessness. The heavy misuse of substance may cause some individuals to drift into homelessness, while homelessness may also reinforce the misuse of substances as a method of coping with the stressors and dangers of living on the streets. The experience of stress has been associated with an increased vulnerability to develop substance use disorder, and therefore many believe stable housing serves as an important factor in addressing this. There's evidence that having a safe place to live can provide stability so that individuals can focus on other aspects of their health. Efforts to prevent homelessness, like housing first and permanent supportive housing, contribute to improved substance use outcomes. Stable housing plays an important role in people's recovery from substance use disorder, and the Substance Abuse Mental Health Services Administration includes access to a stable and safe place to live as one of the 4 major dimensions of recovery. Conversely, living without housing has been shown to amplify symptoms of substance use disorder. However, affordable housing within the United States is becoming increasingly less accessible. And then it talks about the interplay of the risk of social determinants of health, food insecurity, poverty, mental health, and incarceration amongst those. And it mentions then the three options for housing, which is recovery housing, which you think of as transitional housing. The requirement is that you must be in recovery to be there. There's permanent supportive housing, which is for people that have a variety of underlying health issues and need really big wraparound and additional support. And then housing first, that provides housing on a zero judgment, everybody deserves housing basis. Knowing that regardless of the rhetoric in our community, if people have a stable place to be, a stable place to sleep, they're much more likely over time, as they stabilize, to engage in behavioral health services, which is both for mental health and substance use disorder. So that was actually, I'm at my, we'll pass my 1 minute. That was what I had to share. We lack all services, but we truly, housing is at the core of it. It really is. And I want to mention too, nobody brought up Rinke's Law, which is a complex and important piece of information to understand. So people can actually go through a process, or I should say attempt, because as Chief Hall pointed out, we have some very sticky situations within our state regarding rights, and we all do deserve rights, but then it gets very complex when someone doesn't have the ability to make choices to keep themselves alive. But Rinke's Law is something that a concerned person, such as a family member, mental health professional, or law enforcement officer may file a petition with the court to request the involuntary commitment of the individual. Rinke's Law came about due to a woman named Lauren, who's now in our state representative, isn't she?
Yes.
Yeah. She lost a friend to drug overdose, and she had no right or ability to intervene, and she got Rinke's Law passed. So anyway, just something for people to learn more about. That was it for me. I hope I got one.
Anybody have any questions?
Aruna did. We asked her to wait.
But
Go ahead, Aruna.
She's still there.
She's there.
Yeah.
almost.
Go ahead, Aruna.
Yeah, my question was, if Eastern Washington's, and this is for Dr. Lutz and probably the second speaker too, all the information was great, but if the rates are higher because of the social determinants of health, then the solutions that we are seeking for Eastern Washington needs to be individualized for our area versus just having general for Washington state, because the issues are different as far as, and we also need, the other thing is we need the downstream approach. We need the recovery housing support, and we need no wrong options, but also too, early in childhood so that the people won't have adverse childhood experiences. So we need approach at both end of the spectrum to prevent the issues from occurring and also to the treatment options for our communities. What do you think?
You know, Arun, I mean, again, I don't disagree with what you said, and I can actually speak more slowly now because I felt kind of over time, so I can actually speak at a more reasonable pace. In public health, we don't look for quick fixes. I mean, the reality is that the public health issues that we deal with right now are decades, generations, multi-generational in their roots. So we look for the root causes. I talked about a little bit, Hallie talked about them. I am not going to be able to solve these crises overnight, next week, next month, next year, in 5 years. We've got to be in it for the long haul. So these social contributors to people's lives have been institutionalized and they are multi-generational. So we really have to understand the history of our country, our society, and why we always have to have a other population that has to suffer because of these issues, because of how we have developed as a society. As I mentioned before, I would argue we have an unhealthy society. We have a very unhealthy society. You know, we reach the substances because we want to feel better. I won't even talk about politics right now going on, but I will tell you that as a public health professional, as a clinician, as a human being, I am incredibly concerned. You know, I'm incredibly concerned for the people who don't have, for the people who don't have and are going to have even less because of the infrastructure that admittedly is broken, but how it's being devastated, I would argue, is going to be a challenge for us to address for years, if not decades. So to Aruna's point, yes, Eastern Washington demographics are different, but social determinants of health are what they are. Okay, these are contributing factors. I can go Eastern Washington, Western Washington, I can go to Nebraska, I can go to New York. Doesn't make a difference. These long-standing societal factors of how we have developed as a society have created a environment that does not have a social support network for when stuff happens. And stuff happens. You know, stuff happens all too frequently. But if I don't have somebody to help me up, to hug me, to kind of, hey, Bob, I've got your back. Bob, I'm in front of you. You know what? Because I don't want you to take this hit. I'm going to take the hit for you. You know what? Bob, I'm going to walk beside you. I am going to be there with you when you need me. You know, the one, I think about COVID for me. I mean, that was for me such a defining time. And I can't help but think, you know, this is the 5-year anniversary. And tomorrow is 5 years from the first case of COVID that was identified in Spokane.
Yeah.
Okay, I remember that day vividly, folks. But there was such a willingness to work together, to collaborate. It was all about us. And then something happened. We reverted back to, you know what, it's all about me. You're not going to make me wear a mask. You're not going to make me get vaccinated. Okay, I'm doing this for the public good. Okay, I would ask you, do you care about the community in which you live? You know, I rhetorically ask people, do you care about other people that you live with? Do you care about your community? If you do, then you're a public health person, pure and simple. Pure and simple. You don't need a couple letters behind your name. You care about your community. You are a public health person. Okay. I saw that. We all saw that early on in the pandemic. It was, oh my gosh, this is what our society should be all about. We're going to do this collectively. And then things change. And then things change. It's all about me. And you're not going to make me wear a mask. And I don't care about the fact that I could infect you because I don't want to wear a mask because it's my personal liberty that you were impacting. So I can go off in the soapbox and I apologize. But for me, this is such a passionate issue. And I would just say that Aruna, you're right on. But it takes a long-term approach that I will probably not see in my lifetime, but we've got to start someplace. And COVID was a wake-up call. And I would argue the substance use epidemic that we're dealing with right now is a huge wake-up call that's like, come on, folks, do something differently, because what we've been doing is not working. Sorry.
I have a question, Kevin, I'm wondering what informed you and your more humane, community-based approach to being an officer of the peace?
That's an interesting question. I started working with a population of substance users probably a decade ago, and I had the good fortune of working with some folks, a medical director of a 24/7 clinic, when we were trying to figure out what do we do with these folks? We knew they don't belong in jail. They just don't, and jail probably exacerbates the problem in many different ways. So we came up with sort of this innovative program, long before it became a part of the national drug policy or any of that, called the pre-arrest deflection, where we said, look, you have these we call them pocket drugs, just personal use drugs. Do you want to go to treatment instead of jail? And invariably they'd say yes. It doesn't matter if they walked through the door and watched the cop drive off and then they walked out, the charges were gone. At least they got through the door. And then maybe next time it's a chronic relapsing disease, they'll actually go in and do an intake. And then maybe next time they'll do an intake and go into induction. And so it's sort of that problem solving sort of model where it's like, what we're doing isn't working and it hasn't been working for years. Let's try something new. Maybe this will work. And it seems to be far more compassionate to a group of people who really they're just using drugs. They're not hurting anybody but themselves. So let's try and give them something different than jail.
Got a question that maybe applies to all three of you. I'm wondering, as I'm listening to this, remembering reading in the newspaper just recently that in Congressional District 5 and also in 4, okay, we've got a population where the children are all on Medicaid. And in 5, it's over 50%, but it's like 70% in District 4. And I'm wondering to what extent was it impossible for the hospitals to run some kind of a psychiatric ward that would do the no wrong door facility? Or to what extent is it because of no insurance that you can't find a bed for them when you've got a person that's ready to get treatment, wants help, and you can't find a bed for them? And to what extent are efforts to try and help the people that you're trying to help thwarted because they can't go see a doctor who will deal with the problem because they have no insurance?
And just to clarify, Congressional District 5 is report.
Yeah.
Just to clarify.
That was an education for me. Like Arizona Medicaid expansion state is a much different, and most of what we're talking about are billable hours there, and that's what they use. When I got here, I found out that's not the case. And if I ever thought in my 33 years of law enforcement, I'd be digging through Medicaid rules and restrictions and what a billable hour is and what it isn't, it's another one of those policy issues that I want to address, but I want somebody who has far more expertise in it than I do to address as we work through this, and I'm sure you do.
For all three of you, is that part of your problem?
We work regularly with people who are uninsured, and actually part of what caused the founding of CAT was the gaps in care, and one of the gaps in care that we meet And granted, we actually try not to advertise it because it could shut us down because be doing so much of it is providing services to people who are uninsured. So if someone walks through our door and they don't have insurance, we provide them the same level of care as they did. And we have always done that. There are at times we were recipients of a HCA grant that allowed us to pay for services for any type of care for people who are uninsured, but of course that was a short-term grant. We spent all the funds getting folks into a variety of medical options and then that grant expired, but it is an issue. I know when we talk about substance use, I think a really important thing for people to recognize too in the insurance world is that people on Medicare are oftentimes not covered for outpatient treatment services. I didn't recognize that at first because within the language it says they are, but it's only if it's a medical provider providing it, not a substance use disorder counselor. And that's two very different things. So there are definitely significant areas, significant populations of people that are very impacted by lack of insurance.
I'll just say that, yeah, it's an incredibly obtuse, complex system that does not necessarily incentivize people to go into the field. So to be employed in behavioral health is to work long hours with minimal pay and deal with very, very difficult situations. So there's a workforce shortage. And the policies around reimbursement are huge. And I can bill, but a non-physician can't. Because I've got letters behind my name. That's not the way it should be, but that's the way the system has been structured.
By design.
I would argue correct.
But that was also very cumbersome.
We do.
Okay. I was wondering, if there was any data or if anyone is looking at folks who have traumatic brain injury, because that's something I didn't realize. I have started with MCAT, the voluntary crisis and social worker, and now with that. And I'm in that, learning about the medical world and spreading the people who are homeless, have these complex medical issues, rare things going on, as well as I feel like I've had several folks who have history of TBI. And they can't work.
Yeah.
Right? So
I don't have data on it per se. I've got more story lived experience on it. And what I do know is that a fair number of the people that walk through our doors seeking help over time, we learn that they have a TBI.
Yeah, and I feel like that's kind of missing in some of the conversations happening around this issue, which is why I'm bringing it up, because I have other questions.
And it's an important point to make. There's a lot of underlying reasons that people are struggling with substance use, and TBI appears to be one of them, but I don't want to speak to it as if that's a data statement.
Do you have data on that?
Off the top, no, but will I find data for you? Yes. You tell me during the same chat system, I will find those data for you.
I would love that data.
And Dr. Lutz, you said that you would provide those slides.
Yes, ma'am.
Is that correct? Okay,
Yeah.
great. Well,
Wanted to add, in my experience, of 9 years working in chemical dependency, I really went out to women because they were pregnant a lot of times and not having any control. They either were too drunk, they had no idea who the father was, they had no idea how they got pregnant, and identifying with the pregnancy. And this is really one of the awfulest things, like, to deal with, because most of these women end up not keeping their children. They are taken away from them, especially if they're on opiates. I don't know the story behind fentanyl in this, but it has to be worse. But I always feel like we have taken away, and women end up on the street and they have no way of making a living. And here they are pregnant, and we take away all their funding and everything away from them so that they end up just a hopeless person without help, and they're pregnant. So we are condemning that child as well as the mother. So this is really one of the places that really need more help is the women in this, even though the men need it too. But because of the double indemnity at the top. Thank you, everybody.
Very quickly, Chief, you showed us some papers, 17 pages long, right? Yeah, so are those available to us at all?
They will be when I finish. I can certainly provide those. Like I said, I think better when I write. I'm gonna that up. You already have mine. And then just before we end, there were a couple of questions about transportation and the trafficking network. I just testified in front of the Senate. The DEA backs me up on this, or the Border Patrol. The vast amount of fentanyl that comes into Eastern Washington comes from Mexico, I-19, I-10, I-5, I-90 through the Tri-Cities. Almost everything we get here comes straight out of the Tri-Cities. It's a pipeline straight from Mexico because it's cheap. It's much cheaper to transport in that fashion than it is to make it here.
We actually just had one of our team members do an interview with a reporter from Canada, came down to speak with us.
Yes.
And one of our team members went to prison for selling drugs, and he sat down with the reporter and shared with her his knowledge of how drugs flow, and it's exactly as Chief Hall just stated. It's not.
Sherry, really quick.
Really quick, is it possible that if we have further questions, that we could collect them and then pass them on to you guys to have you answer? We'll get.
I refuse to answer any more questions. Keep getting on soapboxes. I mean, I think. Okay, fine.
Leave it there.
Going to let us know, we can collect the questions and then get answers back. That would be very useful. Thank you.
All right, sarcasm.
Well, it's up to you all. We have to be out of here, right? Don't we? Yeah. Oh, okay. Okay, now we have just a few short announcements about some league things coming up, so.
Yeah, so thank you so much to
Yeah.
our speakers. I mean, this has been an amazing program, and to the Affordable Housing and Homeless Solutions Committee for organizing.
Yeah.
We do have a few announcements that are super important. I know Renell has one, Ruth has one, and I have two. Is there anybody else? Raise your hand if you have an announcement that you want to make. No, okay, so the two that I need to make is this Saturday, from 2 o'clock until 5 o'clock is when we're going to have our consensus conversation about the elder care study. I hope you are signing up for it and that you have read the study. On Wednesday next week, we will have the consensus discussion about welcoming immigrants to Washington State. So also please sign up for that consensus. I mean, this is the process that the league goes through to arrive at positions on policy matters. You know, there's a lot of research done, there's a study written, there's reading that needs to be done, and conversations to be had and decisions made by us in Spokane about whether or not we think recommendations are important. And I can imagine that there will be something about this particular issue, you know, coming up in the not too distant future, you know, study and whatnot. So please, Saturday and Wednesday. Ruth.
Quickly, I get to tell you that happy stuff, which is they're gonna celebrate on the 22nd. So if you, did everybody get your invitation? Did everybody RSVP? We're celebrating our 75th anniversary for the League of Women Voters here in Spokane. It's a big deal. Lots of people have put a lot of time into it. We pulled from archives, lots of fabulous material pulled together. We also have a performance with the Gonzaga Theater Group. who are coming to do one of their vignettes that they did recently, that some of you may have seen. And a campaign toast. We're being, catered by Feast. So it's gonna be a lot of fun. So we open the doors at 4 o'clock at Hive, the 22nd. Program starts promptly at 5 o'clock. We'll try to get you all out of there by 6:37, and we'll have to break everything down. 4 o'clock, the doors open. 5 o'clock, program starts promptly. RSVP, super important. If you haven't, please let me know. I have a sign-up sheet if you haven't RSVP. And
And the reason for that is because of catering.
Yeah.
By tomorrow.
yeah, we have basically 48 hours to make some commitments here. So the sooner you let us know, the sooner.
Okay, we have one more announcement from Luna.
Yeah, that's it for working in small groups. Ruth assures me that you don't have to be 75 to go to this party. So I just, if somebody's anxious about age stuff, it's really something. So I want to tell you that the way that we're going to be able to impact the issues that you've heard about is that we have in league a position on it, and the way that we get to a position is we all talk to each other. We don't vote. We all talk to each other, and that's what Elaine is talking about, the consensus process. And it always starts out with a study because we like to know what we're talking about, because one of the things that the league has that a lot of other groups don't have is credibility, and that's really precious. The national is doing a little bit different consensus process, and it is a study on the judiciary, and that'll be very important. It is not, it's not a horrifically huge thing. Sunday was able to go through it and come up with some opinions, and you will have in your information, you'll be able to see where it is that you go online to participate in the judiciary consensus process. So that's a national study. And
9 briefs, 8 briefs, 2 to 4 pages, and so informative, a lot of bulleted items, really well done. So I highly recommend doing that.
When is
And that information is available to you online through your league website. There's another piece that is gonna be, I'm gonna throw something at you two. Bob and Mike, stop it. Hold on.
You're confusing the owl.
Owl is going crazy. Sorry, and I'll be the next person to call out if you're talking too much. You know, is doing about political situations absolutely crucial, and you have an opportunity to participate in that very important meeting. And that information, it's going to be on Zoom, and we of course are not going to advertise the Zoom link, but that's going to be available to you, and we'll make that available to you, and it's coming up very, very soon. So be aware that there will be a response about what the league nationally is doing about the current situation. Thank you. Thanks for that.
Yeah, I'm Sherry Gunchitano. I'm the chair of the Affordable Housing and Homeless Solutions Committee. And it died. Again. On the newsletter, we do have our lwvsaahhs@gmail.com email. It's at the very bottom of the article with the list of our speakers. If you email to that, any questions you have, we will get them to the appropriate person to get a response. And then we have our Zoom meeting the first Sunday of the month. Usually it's either 5:30 or 6:30 p.m. and it lasts about an hour. The only time we don't do that is obviously through the holidays, and then also the first available Sunday in September, because I'm a football fan and that's opening weekend. So they are always gracious enough to reschedule that one for me. But if you're interested in joining the committee and learning more, please please come to our Zoom, contact us by email. My phone number was on there. And find out more. Okay, so thank you, and please help us with cleanup. We only have 24 minutes.
Where do you need chairs?
Yeah.